afternoon program. So thank you all for joining, and thank you for inviting Amerigroup once again. We're excited to be a part of the Spring Medicaid Fair. My name is Ryan Thorsbakken. I'm the Chief Operating Officer and Director of Operations for Amerigroup Georgia. We have with us a whole litany of individuals who will introduce themselves when they come up for their sections. But we're very excited to talk about a little bit about what we've been doing and answer some of your questions. First I'm going to get into our mission and objectives. So Amerigroup obviously is focused on achieving health and wellness for our entire families. We listen, respect, and engage families to understand their culture, values, beliefs, and lifestyles so we can develop meaningful relationships. And we engage and support members and families and set goals based on what is important to them, building on their strengths and enhancing each person's resiliency. The first, and main discussion point that we're going to hit on for both Lori and I is around claims. So obviously operations and claims, pretty close to home for me, so we're going to hit on that. And we really wanted to look at this from a collaborative standpoint. So, recognizing that the claims life cycle begins with the provider and goes back to the provider, right? So it's a large circus. So it flows through us. We look at the claim, we review and pay the claim appropriately and send back to the providers. But we recognize that sounds simple, but that process is rarely as simple as I just stated. So it can be a complex process. There can be intricacies involved that cause things to go off kilter. And we want to be a part of the solution to that issue. So we are, here working with you. We have a table set up in the back with our claims folks to address any questions or issues you might be having. And we really recommend that you reach out to those folks. Also work with your provider reps, as you see as well. We have a provider representative table set up as well with some of our best folks out there. And I want to just, discuss a little bit about our data accuracy. So I think it was mentioned this morning around provider data loads and things like that with some of the various presentations, and that is center point for us as well, making sure that everything is loaded into our systems correctly, ensuring that what's being submitted is correct when you're sending in a claims form, so that we can adjudicate your claims as quickly and efficiently and accurately as humanly possible. I wanted to touch on what our timely filing standards are. So we just wanted to remind everybody that our timely filing guidelines in Georgia is 6 months from the date of service. So just a reminder to submit your claims within that time frame. As well, if there's an adjustment needed, submit your adjustment request in that time frame as well. Submitting claims within that time frame obviously helps us to ensure that we're processing your claims efficiently, but also that we are ensuring that financial stability is occurring. So you're getting your claims in timely, you're getting compensated appropriately timely as well. Wanted to discuss a little bit about prior authorization. So hopefully you were able to join Peach State's presentation. They had a good kind of life cycle of how a prior authorization went into effect. I'm going to talk about it from just kind of a claims perspective. I'm not a clinician. I don't work directly within our utilization management team, but prior authorizations are pretty important from a claims perspective. So from a claims perspective, obviously ensuring that a prior authorization is in place when a claim is submitted is key, right? So for us, from a very clear standpoint, if there is a prior authorization required for a service and you submit a claim for it and you have that authorization, it's clean, it's very smooth, it goes through the system very smoothly. If that prior authorization has not been obtained, or if there's not enough units, or whatever the issue might be, that's a pretty quick way to have your claim denied. It becomes a much more difficult process. So make sure that you're going through the prior authorization process before submitting your claim. Ensure that any claims being submitted have the appropriate amount of units, all that kind of stuff. If you're having issues with that prior authorization process as well, in particular with claims denying, once again, reach out to your provider reps, reach out to our claims table back there for direct help if you need to speak with someone. Speaking of the provider account managers, wanted to hit on a couple points about our provider team. So we have provider account managers that are supporting providers directly that you can reach out to. We also have a really wonderful intake process where you can submit directly to our intake You can submit a ticket, you can follow the ticket, and you can get feedback directly from our provider team when those tickets are submitted. And the implementation of that process is somewhat recent, so there's been a couple instances where there's been bumps, but that team has been working really efficiently to ensure that that process is flowing smoothly. If you are having any issues, please reach out and talk to your provider team. I'm going to bring Lori up actually to talk a little bit about our claims volume and a little about our claims data as it's related to the processing. Go ahead, Lori.
So thank you, Ryan, and good afternoon, everyone. We're talking about the money. I know everyone does a job and we all want to in return get paid for the job that we're doing. We at Amerigroup are here to service you, our providers, as well as our members. So I am pleased to announce that over the past 18 months, we have processed nearly 7.3 million claims. Of that percentage, 95% of those clean claims were ultimately paid. We had a smaller percentage in that bucket, 5% that were rejected and or denied. And those we look forward to you all reaching out through our intake process, through our call center, through your provider reps if possible, to engage in question, and we could work with one another to see why those claims were denied and hopefully work to resolve for payment. We're very pleased to announce that's a lot over the past 18 months when you look at it in a huge realm. The payments mean a lot, but the denials mean a lot as well. And we're definitely here to partner with each and every one of you to ensure that we're working to assist you all and vice versa, because ultimately it's our members that are at stake. Don't have any questions. If you have any questions, I don't have any other comments other than that. But if you all have any questions concerning the claims team, as Ryan stated earlier, we have our great claims partners over at the claims table who could definitely answer any of those concerns you all may have. Okay. I would like to bring up our grievance and appeals rep to discuss. Oh, you're next, Monica. My apologies. Monica Lester to discuss contracting. It's backwards.
Good afternoon. Apologize for our technical difficulties. I'm Monica Lester, Director of Network Management with Amerigroup, and I'm going to spend a couple of minutes talking about our provider complaint process. So the initial stage is a claim payment reconsideration. So if you have a claim that's been underpaid or you just feel it's been denied in error, the first level of appeal is a payment reconsideration. We need to receive that within 90 calendar days of you receiving your explanation of payment, or EOP, from Amerigroup. We can receive those verbally, it can be mailed, or you can initiate the process through Availity. The next level is a claims payment appeal. If you're dissatisfied with the outcome of the claims payment reconsideration, you can submit the second level, which is a claim payment appeal. We need to receive that within 30 calendar days of you receiving the provider, receiving the determination from the claims payment reconsideration. And then the next step in the process, if you're unhappy with the level 1 or level 2 appeals, is an administrative law hearing. And that request needs to be received by Amerigroup within 15 business days of the claims payment appeal decision. And again, on this slide, we just detail the various avenues you can submit your payment dispute requests. So the first level reconsiderations, we can receive those verbally. You can submit online through Availity, or you can mail in to the PO box that's listed here on the slide. We also have a process around non-claim related provider complaints, and those are usually specific to Amerigroup policies or procedures or administrative functions that you as a provider you don't agree with. And so you can submit a letter to us, Health Plan Operations, at the address listed on this slide, 740 West Peachtree Street. Just going to take a couple of seconds and highlight some of the provider complaints or the appeals that come in, what we see. So we see demographic errors where we don't have all of the addresses loaded for a provider. We get provider loading delays, which can cause claim issues in terms of if we haven't loaded your provider, if your provider's not loaded correctly, you may see a denial for an authorization, which may not be accurate or correct. So those are some of the top complaints. Some of the things we're working on to improve the number of our systems and to reduce provider complaints is just some system enhancements to reduce provider loading errors and working with our partner DCH to improve data accuracy in the 7400 report. And the goal again is to increase provider loading accuracy and decrease the number of claim issues that we're seeing. And I will turn it over to Brantley Nelson, and she's going to talk about the member grievance and appeal process.
Good afternoon, everyone. So as mentioned before, we discussed a little bit about the provider path. Excuse me. There's also a member grievances and appeals process that we'll briefly discuss today. So a grievance is typically an expression of dissatisfaction. Normally these are non-clinical, but they also include quality of care. So that could be something like the condition of the provider's office, wait time, things like that. Our members are able to submit those dissatisfactions to us. On your screen, you see that there are multiple pathways to do so by phone, fax, and also mail-in. And just some general information that the member has to submit is a detailed description of the issue. That's going to be the most important thing. And what happens once we receive it, we'll send out an acknowledgement letter within 10 calendar days. We'll investigate the grievance, and then we'll send a resolution in 90 calendar days. We do pretty good with this. So as you see on the screen, we meet at 99% compliance for our resolution letters, also above 99% for our acknowledgement letters. Some of the things that we typically see will be our provider balance billing. That makes up the majority of our grievances, followed by difficulty locating an office or a delay in treatment. When we do get these, we do work closely with our providers, contacting them directly to try to assist, particularly with the balance billing, because our Medicaid members cannot be billed. And then if any issues come up, we do have our provider reps that can assist. So as mentioned before, there's also a member and provider appeal process. Now these are going to be clinical in nature. Typically you can file an appeal within 60 calendar days in our state. And then on your screen, you see ways that you can do so by mail, phone number, and fax. Also, providers have the ability to do so electronically through Availity. And you're going to want some key information, the name of the provider, type of service, member identification information, and if you have it, the prior authorization number for your authorization that may have denied. So once we receive these appeals, we'll send out an acknowledgement letter within 10 working days. These are going to be our standard appeals. There's also an expedited appeal process, which are 72 hours, you'll get a phone call within that first 24. And then for our standard appeal process, after the medical director has reviewed them, you'll receive a letter within 30 calendar days. If it's expedited, again, that'll be 72 hours, and you'll also receive a phone call. So we do very well in this aspect too. Over 98% of our resolution letters are sent out on time. And as well as our acknowledgement letters, we resolved 3,309 of those. And on our next screen, we see the physical health top categories. Most of these fall into dental and pharmacy. And so with these, we do work closely with our providers. Most of the time, the appeals come because we don't receive everything we need on the front end. But once we receive those medical records and our medical staff has a chance to review, they are overturned in those cases. And then if they're not, there is another path that you can take. And on the behavioral and mental health slide, those are usually outpatient services that we see appealed. Again, typically this is because we don't have all the information on the UM side. And so once it reaches the appeal level, a medical decision can be rendered. And so a little bit about our provider appeal compliance, similar to the members. We usually resolve these 97% compliant. Expedited, so we always get those 100% of the time, even so year to date. And our acknowledgement letters, basically acknowledging that your appeal was received, we complete those 98% of the time, on time. For our providers, it's typically inpatient medical that we see in our appeals buckets. Again, those are typically because we don't have the medical information up front, but we do work closely with our providers and overturn where we can. And similar for our behavioral health side as well. And with that, we're going to talk a little bit about network adequacy, and I'm going to turn it over to Monica.
Okay, so I want to talk a little bit about network adequacy and some of the criteria Amerigroup looks at when adding and selecting providers to the network. So the first is time and distance requirements. We ensure providers are located within the required geographical and time requirements to meet member needs. We also assess the quality of a provider. We review provider performance and outcome data with the goal of improved patient outcomes. We also consider provider diversity. Our goal is to develop a network of diverse providers to serve members of various cultural and linguistic preferences. We also want to promote inclusive care environments that can support unique patient demographics. Provider access and availability is extremely important. We want to ensure we have a range of provider specialties and services to guarantee comprehensive care for our members, and we want to assess provider capacity to accommodate timely appointments and minimal wait time for our members. And we also consider telehealth capabilities. We want to ensure that there are telehealth options and that they're integrated within the network to expand access to all members. And then the last slide up here for the network is just the various avenues to connect our wonderful provider relationship account management team. You can visit the contact us page on the Amerigroup website. You can email the provider relations team at the address below, and then you can also stay connected with us by reviewing our provider communications at the email address listed. And so next, I will turn it over to Sharonda Jones, and she's going to talk a little bit about care coordination and care management.
Good afternoon, everyone. Can you all hear me? All right. My name is Sharonda Jones. I am the manager for the Physical Health Case Management Department at Amerigroup. Today, I will be walking you through how Amerigroup's Care Coordination Department supports our most vulnerable members. Amerigroup's case management program aims to coordinate comprehensive care so that our members receive efficient, well-coordinated services at the right level through personalized programs in collaboration with community services. Amerigroup identifies members with the greatest need for case management, including individuals with catastrophic conditions, members with complex conditions, high-risk pregnancies, infants and toddlers with compromised conditions. We do have specialized programs for members that have cancer, members that have chronic diseases such as asthma, diabetes, and hypertension. We do have an emergency room avoidance program that supports members to remove barriers to receiving care in the primary setting. We also have a post-discharge management program to support members as they transition from being inside of the hospital to transitioning home. So the first step with our case management program is the initiation process. There's three parts to this process. The first part is to screen members. Amerigroup identifies members for case management through providers. We have internal departments such as our member services team. We also have a proprietary predictive model program that identifies members using a dedicated algorithm such as claims, inpatient utilization, chronic conditions, and other provider services that would most benefit from case management services. Once these members are identified, we do perform outreach to these members. We do attempt to reach these members 3 times within 10 business days of being identified. We use different modalities for these members, such as text messages. We do telephonic phone calls. We also send mail letters to the members' home just to let them know that we are here for them and we can support them with getting all of their care. Our third part is the assessment. Once our members are outreached and engaged in our case management program, we do a very detailed assessment to identify comprehensive clinical needs as well as psychosocial needs with these members. We use input from the members' own claims of what they need. We also use medical history as well as provider feedback to create an individualized plan of care. So the program requirements, anyone enrolled with Amerigroup is qualified to receive case management services. We do target members, ones that are most likely to benefit from these services as well. Members that are likely to benefit from these services are stratified into categories of low risk, high risk, and severe and complex risk. Members who are not likely to benefit from case management services are steered to other departments such as member services to answer questions about benefits. We also direct our members to their providers if they need different exams done, such as a wellness check. We also direct our members to our community partners for SELH needs, such as transportation services, as well as food assistance, utility assistance, amongst other things. So the classification process of our members, it helps us to focus on those that are most complex and have the greatest needs and require the most intensive support. We target the right population just so that we're able to provide meaningful interventions that lead to measurable improvements and better outcomes. So just walking through our case management program, I did want to highlight our typical member journey to success. This is just a demonstration of a member that we were able to engage in case management to support their needs. This member is a 58-year-old female who had a history of uncontrolled hypertension, asthma, as well as having a non-ST elevated MI. She was referred to our program through the post-discharge management services to support the transition from being in the hospital to getting her care in the outpatient setting. During the enrollment process, our nurse was able to outreach the member within 7 days of discharge. She was enrolled in our case management department, as well the care coordination department, as well as transitioning to the disease management program. During the enrollment, there was a detailed assessment That includes a review of her history. This particular member had a pattern of missing her PCP appointments and had medication non-adherence. This particular member frequently visited the emergency room to receive treatment. During our post-discharge management program, we were able to ensure that this particular member had close follow-up with her outpatient providers. We helped her to schedule visits with her cardiologist, as well as provided assistance with her hypertension management through our remote patient monitoring program. This member also had issues with getting to her doctor's appointments. We were able to arrange transportation services to help support her to getting to those PCP visits in the outpatient setting. After being enrolled with our program, she was able to follow up with her PCP, her cardiologist, and a pulmonologist within 6 months of being discharged. This member was also referred to our behavioral health department due to anxiety related to her chronic conditions. She received ongoing education throughout her participation with our case management department. We educated her on techniques of how to keep up with her medications. We made sure that she understood her medications, as well as providing support from a pharmacy standpoint to make sure that if she had any authorization issues, she was supported through that process. Also, we were able to make sure that she was compliant with her blood pressure, receiving that ongoing remote patient monitoring from managing her blood pressure using a cellular connected blood pressure cuff for 6 months. Throughout that time frame, we did make sure that her blood pressure stabilized, and within 6 months she was below the HEDIS measure for blood pressure control, which is 140/90. Throughout these consecutive calls with the member, we made sure that there were no additional needs that she had, and we also made sure that she was well equipped to self-manage her condition before graduating from our program. This is just one of the examples of how we support our members from a case management standpoint. Thank you so much. And I'll turn it over to Dana Wheeler for prior authorization.
Hey, good afternoon. All right, so my name is Dana Wheeler. I'm the manager for the inpatient department, and I'm gonna go over the prior authorization life cycle. So the objective here today is to just provide a comprehensive overview of the prior authorization life cycle, ensuring that you have the knowledge to streamline the request and address any prior auth concerns effectively. So there are 4 stages of this life cycle of a prior auth. We have the initiation stage, which is providers see the patient, a member, identify that there is a need for a prior auth. Then, you verify the member eligibility and benefits. You determine if a prior auth is required or not. You can do that by utilizing our pre-certification tool. It's a pre-certification lookup tool called Pluto. And it is found on the Amerigroup provider website. Basically, with that, you can pretty much enter a procedure code or a description of the procedure that you want to perform. And it will pretty much let you know whether or not a prior auth is required. All right. Authorization are required for services from out-of-network or non-participating providers. Part of it, what you need to do is, gather information, the necessary information to get ready for the submission. which includes clinicals, physician orders, appropriate diagnosis codes, procedure codes, dates of service, and the number of units required. Stage 2 is the submission. Completing the submission, the PA request with supporting documentation. So PA certification requests may be submitted through the Georgia Medical Management Information System, which is known as GAMIS. And as you see, the website is there. You can also submit requests through the Avality provider self-service site. Supporting clinical information can be uploaded to the auth via GAMIS or Avality. No faxing or phone calls are needed. All prior authorization requirements are found at the website, and you would just select Georgia. So once we receive the information, it goes through a evaluation process. So prior auth review by Amerigroup include auth submitted via GAMIS or Avality. They flow seamlessly into our Amerigroup prior cutting edge prior auth platform. The medical necessity review is conducted by well-trained and licensed physicians and clinicians. Amerigroup utilizes evidence-based criteria such as INTERQUAL, Amerigroup Clinical Guidelines, and Amerigroup medical policies. These criteria are available to providers via the Amerigroup provider website. Now we're looking at our turnaround time. Amerigroup must be notified of an inpatient admission within 24 business hours of admission, with supporting clinical information attached to the notification to turn the decision around within 24 business hours. If clinical is not received within 48 hours of admission, the case could be disallowed for lack of information. Standard outpatient and elective inpatient authorizations are processed within 3 business days from the date of receipt. Expedited authorizations are processed within 24 hours of receipt. Then we have our reconsideration or peer-to-peer request must be received within 2 business days from the issuance of the notice of adverse determination. All right, and stage 4 is our outcomes and follow-up. So approvals can be viewed by the provider in almost real time via the GAMIS or Avality website. Providers can then proceed with treatment. Requests for additional information. There may be time where we, Amerigroup, may request for additional information for decision making. Additional information is requested via telephone calls to the provider. Providers can also upload additional information via GAMIS or Avality. Prompt and concise response are needed from the provider for timely decisions and to avoid delay in the care of the member. Denial. Prior authorization may be denied after a review. A copy of the denial letter is sent to both the member, provider, and facility if applicable. Denial letter include details of the reason for the denial and how to request an appeal. Here are some of the reasons for denial. We have a situation where we don't have all the information, so we got our lack of support and clinical information. We have insufficient clinical information being received. There may be benefit or criteria guideline limitations, failure to submit updated progress notes, services provided prior to receiving a prior auth. are there those instances of non-covered services or item? All right, so handling denials, review the denial reasons. A letter is sent out to the member and the provider for any disallowed service. Review the denial reason carefully. This is critical for addressing any outstanding issues. Reconsideration, providers can submit additional information via Gammas or Validity and request for a reconsideration review within 2 business days from the issuance of the notice of adverse determination. We have a peer-to-peer. Providers have the option to request a peer-to-peer review within 2 business days following the issuance of the notice of adverse determination. This process enables the servicing provider, practitioner, to engage directly with the Amerigroup, medical director, or practitioner to discuss the case further, providing an opportunity to potentially overturn the denial if medical necessity criteria are satisfied during the phone conversation. You can submit the peer-to-peer review via email, medical peer-to-peers at georgiapeer-to-peer@anthem.com, and therapy, PT, ST, and OT, peer-to-peers, therapy, Georgia@anthem.com. All right, and just a few best practices for providers. Use a prior authorization lookup tool on the provider website to determine if a service requires a prior auth. Use Gammas or a Validity portal to check the status of your authorization. It pretty much uploads the status of the authorization within 15 minutes of throughout the day. Verify the use of correct ICD-10 CPT codes when submitting your authorization request. Ensure that all the associated clinical for service is submitted at the time of new authorization request and with requests for continued stay reviews for inpatient admission. You want to verify the member eligibility prior to auth entry and prior to rendering services. You want to notify HCM/UM nurse daily of discharge needs to prevent delay in obtaining authorization for services. Ensure all necessary information is complete and accurate. Keep informed about payer policies and guidelines. You want to keep members informed about potential delays and outcomes, and embrace our electronic prior authorization system for efficiency. All right, and now I'm going to just turn it over to Lakeisha. What we have here, lastly, is ongoing therapy such as physical, occupational, and speech therapy. These are services that require prior authorization, durable DME equipment, home health care, pain management, OB deliveries, and all inpatient admissions. Okay.
Good afternoon, everyone. Can you all hear me? Awesome. Well, good afternoon again. My name is Lakeisha Williams, and I'm the Director for Behavioral Health Services at Amerigroup, Georgia. I am also a licensed professional counselor, so I'm very passionate about the work that I get the privilege to do every day. How many of you actually are behavioral health clinicians or work for a behavioral health clinic or agency? Awesome. Hand clap to the BH providers in the house. So thankful that you guys are here. And Dana went over the prior authorization process, which is the same for physical health and behavioral health. However, I just wanted to highlight some nuances, especially as it relates to what's required when you submit a prior authorization for behavioral health services. But first I'll talk about what needs a prior authorization for behavioral health services. So first is any type of PHP service, so a partial hospitalization or intensive outpatient program, you're gonna need a prior authorization before that member is able to receive those services. Of course, your residential treatment facility. So if a member actually needs a residential facility, before they can go to that facility, there has to be an approval for that member to receive those services. Same thing for acute inpatient care as well as our crisis stabilization unit. That's on the inpatient side. For outpatient services, the things that require a prior authorization are our assessments and assessment updates, essentially. So H0031 and 32 do require a prior authorization, but I do want to share a caveat that prior to needing a prior authorization for an assessment or treatment plan, you do get 16 units per member per provider before a prior authorization is requested. So that is done to help ensure that that member does not have a barrier to being able to get the services initially started. Amerigroup, as you guys may know, is the only CMO that provides managed care for our foster care population. With that, we know that our foster care population is often transient. And so they may be living in South Georgia one week and then the next week they might be in the metro Atlanta area. So if that member has to move to a different area, often they have to get a new provider, right? And so we want to make sure that even if they go to the new provider, they get a fresh 16 units to be able to utilize before a prior authorization is required. So again, when it comes to assessments, you do have 16 units per provider per member before you have to submit a prior authorization request. That's the same thing for therapy. With therapy, you get 20 sessions of therapy before you need to submit a prior authorization to us to request those services. And again, it is per provider per member. So again, if there's a member who's seeing a provider in South Georgia and then they have to move for whatever reason and they're seeing a new provider, that new provider gets a fresh 20 sessions to be able to use before a prior authorization is required. Other services that require prior auth is our CSI, IFE, any of your medication assisted therapies, assessments, as I talked about, but again, you get the 16 up front, IC3, as well as any ABA services. And then lastly, there is a prior authorization required for psychological testing. Let's see if I could get this to move. Okay. So as we talk about the prior authorization process, we work really hard to make sure that when you submit that request to us, you get a very quick response. So when it comes to inpatient requests, if you send a request to us for an inpatient stay, we're going to turn that around within 24 hours. And that is including those decisions that come in on concurrent review. When it comes to PRTF for the initial request, we have 3 business days to get a decision back to you. And those days are really important because PRTF is really our most restrictive and intensive level of care. And so when we're reviewing those requests, we want to make sure that this is a member who actually needs something that intense, that restrictive. And so we do take a little bit more time. Again, only 3 business days to get that decision made. When it comes to PHP and IOP, those are done within 3 business days, as well as our core and IFE services that I talked about earlier. When it comes to where you submit your prior authorization requests, there's 2 different ways, and it really depends on which type of care you're requesting. So for psych testing, IOP, PHP, and for PRTF, you can do that through availity.com. That's Amerigroup's platform. When it comes to any type of outpatient behavioral health services, that's including ABA, that's done through GAMIS, through the state portal. You can also request residential treatment through GAMIS as well. So you get to choose if you would prefer to go through Availity or through GAMIS when it comes to a residential request, because it is available there. And this is our attempt. We've been working with the state to get more and more behavioral health services on the GAMIS portal, so you don't have to do some things on Amerigroup portal and then other things on GAMIS. So more to come with that. When you're submitting a request, of course, when you submit, you want to get it approved, right? Everybody's submitting to get an approval. What helps and ensures that your request is approved is making sure that you document appropriately. So I want to talk about what we need to see when you're submitting a request to us for prior authorization. First is we need to see that this member has been assessed. What is the presenting problem? What are some of that member's histories? What are their strengths? What are the things that they have going well for them? What are some of the barriers to them being able to get better? What is that member's diagnosis? So being able to show us all of the information that you gathered to show that this member needed whatever level of care. If they need IFE, what type of assessment and what information did you gather to demonstrate that that member needed IFE services? After you've done the assessment, we want to also make sure that you're including the treatment plan. Okay, you've identified this member history, what type of services or challenges they have, what their strengths are. What is going to be your treatment plan? What are you going to be doing to help that member reach their goals? And that's what we need to see in their treatment plan. It needs to be based on the assessment. So if you're stating that when you assess the member, they reported they were depressed, they had a hard time getting up to go to school, we want to see in the treatment plan that there are goals or work that will be doing to help with the depression. If you have anxiety and there are not much about the anxiety in the assessment, it's really hard for us to understand that there is a clear continuity in care for that particular member. Of course, we would need to see any progress notes that you've done, what the work that you're doing, especially once you've gotten the approval and you're re-requesting for concurrent review. And then as that member has been in treatment for some time and you're submitting additional requests, you want to make sure that you're also including treatment plan updates, because we want to see, is the member progressing? What are you doing to help them progress? If they're not progressing, what are the challenges to preventing that member from progressing? Also, when it comes to submitting a request for services, especially for inpatient services, make sure that you complete the template thoroughly and upload it online. Again, as I shared earlier, making sure that any pertinent symptoms, behaviors are actually included in that documentation. One thing that is always missing when we get requests from providers is dates. When did this happen? When was the member depressed? When was the last time they missed school? So making sure that you include the date of when things happen makes it a lot easier for us to determine not only is this the right level of care, but also how much of that treatment does that person need? Because if they were depressed 9 months ago, that was the last incident, do they really still need therapy services? They might, but again, those dates are real important versus someone who was feeling depressed 2 weeks ago. Also including the date of medication changes. When was the last time they had a medication change? Have they been on medications? Again, that really kind of helps us see the member's current state. And then, of course, as you are ending services with that member, making sure that you're including discharge planning information. Actually, from the beginning of treatment, what is it that you're hoping that this member is able to do once your treatment has concluded? What are their goals? Where will you be referring them to? We know that treatment doesn't always go as planned, but from the beginning of treatment, there should always be a goal of what that discharge is going to be. And sharing that in your documentation so we can clearly see that and make a decision that's best for the member. When it comes to outpatient services, again, making sure you complete the form fully. I want to again reiterate, please complete the form fully. We work very hard to determine what questions are on a prior authorization request form. It's not happenstance. It's not based on just something, we saw on the internet. We really work together, often with the other CMOs and with DCH, to determine what we need to see in order to make a really truly informed decision. So when you skip things or don't completely fill them out, it makes it a lot harder for us to make a decision and really can create a barrier for that member getting treatment. So please complete the form fully. Again, addressing any pertinent symptoms and behaviors, making sure you only request what's needed when you're submitting those requests there, what your specific goals and objectives are, and any barriers or challenges to reaching those goals or objectives. And then lastly, when you're submitting your requests, ways that you can help to optimize and prevent any barrier to getting an authorization is really assessing, are you the only provider that this member is seeing? So really asking that client that you're talking to or member that you're working with, are you seeing any other providers? And if so, because that may be the case, like I mentioned, sometimes they may have moved or it may be a situation where they don't want to see a particular provider anymore. We do have a provider of choice form that you could submit with your request, letting us know that, hey, there may be an auth on file for Dr. Smith down in Tifton, Georgia. However, now this member wants to see me, Dr. Jackson, and that other authorization is null and void. But when we see an authorization already on file and we get another request for therapy, that second request could get denied even though that really is the provider that should be seeing the member. So making sure that you document that information when you're sending the request. Again, same thing, if there is multiple providers, sometimes it's justified, right? There may be a situation where a member has been working with a particular provider for depression, and then you find out later that there are some OCD issues that this member might be dealing with, and there's another provider that may be the only one in the area that can provide support around that. Sometimes it's appropriate to have more than one provider, but again, documenting why there is another provider and why there may be this duplication of services needed in that request to reduce the likelihood of a denial. And then when it comes to medication, making sure that you're documenting what you need for services and units. Hope this has been helpful. Again, anything related to BH, let me know, Lakeisha, and I'm going to turn it over to Abby to talk about GF360. Oh, ran away too fast.
All right. I need to figure out how to use this first. Hey everyone, I'm Abby. I'm with the Georgia Family 360 program, which is our program that oversees kids that are in foster care, adoption assistance, and Department of Juvenile Justice. I only have one slide that is standing between us and the basket giveaway, so get excited. We have 3 questions that we're going to pop quiz y'all on for the baskets, but just a few brief updates from our end. So number 1, we wanted to make sure that you all knew that GF360 had GF360 provider liaisons. So these are, we have 3 that are liaisons between our 360 population and our provider side of the house. So they're really there, they understand the needs of our members, but also have the relationships and understand the provider side as well. So if you ever have questions specifically around 360 members or need some assistance, you see that we have their email address up here. They also work internally with our care coordinator, so they work hand in hand there as our care coordinators. As you all know, all of our members do have a care coordinator, so they work with them to make sure we're closing those gaps in a manner that's quick and is really specific to the needs of our population. The second thing, this is kind of peripheral to you all, but just wanted to make sure you're aware. So I'm not sure if y'all have heard that DFACS has launched an app called Communicare, and it's a really cool app for foster parents and for caregivers of children that are in DFACS custody. And one of the things that we were able to partner on is to make our ID card available in the app. I'm not sure if any of you all have worked with a foster parent or a family that has a child in foster care. Sometimes getting that member ID card can be a little challenging, and you as a provider may need it. So just wanted you to be aware, if you run into that, you can suggest to the caregiver, hey, if you have the Communicare app, the ID card is in there. So just wanted to make y'all aware of that. And then the last thing, we have our some of our education and training team here. They're on the front row and they are at our table too, but we have a provider education series coming up in quarter 2, so coming up here soon. If y'all are interested, and if you're not already on our distribution list, email us at the website ga360training@amerigroup.com, and we'll make sure we get you all added so that way you can be aware of some upcoming trainings we have specific to you all with kind of a bend towards our child welfare population. So that is all that I have for that. We're going to do baskets, Q&A, and then we'll turn it over. So the first person who can answer this question, oh, hi. Never mind. Take it away, Shanique.
I'm going to try to restate your question. I think the question is, if my rep is on vacation, PTO, how do I get issues resolved?
Yes.
So every rep should list a person who is covering for them when you send an email. So if something is escalated or can't wait until that person is back on PTO, there should be, like I just came back from vacation, so someone covered for me and that person's name and email address were attached to my out of office if you needed to have something addressed immediately. You're welcome. And you're specifically the E&M codes or the PTO, TNST codes? Because there have been.
All right, so the question was, how are we going to be addressing the recent fee schedule updates for the BH fee schedule? So would that be accurate? Yes. Okay, so we've been talking about that quite a bit since the last Medicaid fair. It's been a topic of interest, obviously, internally and with, obviously, our BH providers. So as of now, our plan is to obviously update our fee schedule starting 7/1. We're also looking at some retroactive claims adjustments. We're not exactly certain what that's going to look like quite yet, but we've been working through that issue for quite some time, and we're going to try to ensure that we are able to meet as many folks' needs as possible.
So you said you don't know right now, is that what I'm hearing?
Yeah, we don't have specifically what it's going to look like retroactively, but starting 7/1, the fee schedule will be updated.
7/1 of this year?
Yep, 7/1 forward.
So, okay, so we want to see the payments from last year, from 7/1 of 2024, when the claims became active.
That's the piece that's under review right now, is exactly how far back we would go with adjusting this. Yep. Yep.
We got 4 minutes before we have our closed session, and I think you all are going to do a giveaway.
Okay. Yeah, come on up, Abby.
Okay. All right, I'm just going to hold it here. All right. Okay, so our first question, if you remember, him and her spoke at the beginning about claims. Can someone tell me what one of their names is? Oh, I see blue shirt. Yep. All right, good job. Hey, his last name is actually a little challenging, so if you would have remembered that, we would have given you all 3 baskets. Okay, the next question. I heard myself echoing and thought it was someone else talking. I'm going crazy. How many percent or what percentage of claims were denied in the last 18 months? This was kind of, I see a blue male shirt in the back. Yep. Yep. Good job. All right. And then our last question, how many days do you have to file an appeal? Okay, white shirt. Not 30. Oh, I see black shirt. Not 2 days. Okay, oh, pink and blue. 90? Not 90. I hear someone in the back. 60. Okay, good job. All right, thanks everyone.